And Europe does a ton. They do way more ECMO than we do, but they also have no FDA. So I mean, if you look at, I was just actually at a conference a couple weeks ago, and there was a lady from the FDA that spoke. Poor thing, she got really. I felt terrible for her.
Don't.
She was trying to like explain things, and she really got cut into by some of the physicians there. You know, because they get frustrated. Like, we can't do the things that we want to be doing because ECMO is technically approved for 6 hours. It's a 6-hour approval. That's all.
Our can't use that.
6 hours, 300 and some days. Yeah. So it's all off-label. We do everything off-label use, essentially.
Good for you.
Yeah.
Prove
Yeah.
along.
Yeah, it's just that it's not. There's not enough studies, and there's just not. It's just not there yet.
There's your next paper.
Yeah.
What kind of steps are taken to wean a person off the
Off
machine?
ECMO?
Yeah.
So it depends on which type of ECMO they're on. If they're on VV, we follow, you know, their chest X-rays, and they do a lot of bronchoscopies and just kind of watch their lung function. With VV, it's actually easier because it's only on the right side of the heart. You know, it's only pulmonary support. We can actually turn off all of our gas flow, and so then it just becomes circulating volume. The patient's lungs still have to, so we can test them, essentially. So for VV, it's super easy. We just shut off our gas flow, and the blood still keeps moving, but we're not oxygenating, we're not removing carbon dioxide. It just is a right-sided VAD, essentially. So they can be tested, and we had someone that we weren't quite sure if she was ready. We left her off gas flow for like 24 hours, and she did fine, and then we decannulated. The VAs are a little bit more difficult to wean. A lot of times, you know, we just kind of usually slowly just keep coming down on our flows, but we can only go to a certain point because we have to have enough blood flow to maintain the circuit function. So it just depends. Sometimes it's within a few hours, sometimes it's over days that we just slowly start stepping down. So, and then a lot of times, you know, they'll do turn down and do an echo, and then they usually go to the OR to decannulate for the most part.
Does the heart hurt where you need sutures then?
Yep, they're purse stringed into the vessels typically. The femoral vessels a lot of times need repair after.
So you said that you usually don't do a blood prime even if you have a liter of fluid out?
On our adults, we do not do any blood prime at all. It's all, because our circuits are all pre-primed, not all of them, but we have two adult circuits that sit primed and one pediatric circuit that sits primed.
What do you mean sits primed?
Sits in a closet, primed, ready to go.
So you can hook up now.
Yep, with plasmolite actually.
Oh, okay.
Yep, they're all primed with plasmolite, and then for the neonates, we just replace, you know, one for the other with blood, or pediatric patients. And the adults, they go on with plasmolite. It's directly connected. So it depends. I mean, if it's a lot of times I end up giving them blood afterwards. Yeah, but yeah, the adults don't have any problem with it.
So you must be able to do that because you're able to give oxygen.
They're ventilating.
Yeah. Yeah, and we're giving them.
But we can
So
never do that.
the
We should get a little
PO2
plasma
coming out of the
machine.
oxygenator when it's brand new is around 500, 500 to 600 on a brand new oxygenator. So we're giving them a ton of oxygen, so they can tolerate a lower hemoglobin of 4. And usually the adults, it only drops them about 1 gram to 1.5 grams. It's not too bad.
What machines does it do we have?
We have 4 cardio helps. And I think we'll be getting more because eventually we're going to go straight to the cardio help, and we probably won't use the centromag much anymore at all for ECMO. For the VADs, we may still see the centromags, but I think we have 6 centromags.
Lori?
Yeah.
How did you get interested in ECMO?
In ECMO?
It's such a passion of
Yeah.
yours.
I don't know, I was a nurse for several years and just had started taking care of some of the patients first. And just really liked it, so thought, why not? Yeah, so I've been doing it it's about 8.5 years now, but so it's been a lot of change. It's fun. It's super challenging. There's a lot of things that we do that are crazy. You know, like there's things that you just don't ever think of that you see, and so it's fun. It's hard work sometimes, but it's good. We have about 50 staff now, Ecmo specialists. Which when I started there was I think 11 of us. So we've grown a lot, but we've also done a lot more ECMOs per year as well. So that we needed more staff to cover all those patients.
Do you get to travel to Europe to speak to other
No, that's not approved travel. So I wish we could.
Yeah.
The last conference that I was at in San Diego there was a ton of people from Europe and Switzerland and Germany, and they are awesome to listen to because they do all this stuff that we're like, yeah, we can't do that. We can't. So it's all the FDA stuff.
The vast majority of your cases are patients coming out of cardiac surgery who need support in the post-operative period, or?
Yeah, it's probably like 70-30. Like 70% of them are cardiac, maybe even a little more. It just kind of depends. When the H1N1 stuff hit, we had a fair number of VV patients that year. A fair number, it was probably a handful, it was probably 5. But that was probably the most VV patients we had done like all at one time. Otherwise, most of them are cardiac. Transplants. We do a fair amount of pediatric congenital because of our congenital program here. And the VVs just we don't see as many. Although we have 2 pre-lung transplant right now. So that just decompensated and they do ECMO prior to transplant. So